Times have changed, bringing with it numerous changes in almost every aspect of life. Lifestyle has changed. Due to advanced information technology, communications, digitalization, times have changed. Time is critical for virtually everything. Time is the essence. Today, fast world has also created various unwanted conditions like stress, work issues, anxiety, giving couples very little time for themselves. The result: increasing cases of erectile dysfunction. The result: less time for building relationships. The result: unhappiness. Zydus Forteza, a division of Zydus Healthcare Limited, launching for the first time in India the fastest acting phosphodiesterase type 5 inhibitor. Presenting avanext, Evanafil 100 mg and Evanafil 200 mg. Happiness is mutual. Why wait? It's fast. Onset of action in just 15 minutes. Best among all available PDE5 inhibitor. It's effective. Improvement in SEP2, SEP3 and IIEF scores. It's safe. High tolerability and safety profile for diabetes or cardiovascular patients. It has no intake restrictions. Eat and drink what you like. Can be taken anytime. It has least adverse effect. Less incidences of headache, blurred vision and nausea. Let them experience happiness that is mutual. Let's make every patient of ED happy. For the first time in India, presenting the fastest acting PDE5 inhibitor, avanext, Evanafil 100 mg, Evanafil 200 mg. Happiness is mutual. Why wait?
A very good evening. Very good evening to the respected faculty and our viewers. Myself, Dr. Sachin Chaudhary from Medical Affairs team Zydus, would like to welcome you all for today's webinar on testosterone basics and beyond. In Zydus, we have the largest portfolio for the men's sexual health. Our vision is to improve the male sexual health among the men. So to continue our vision, today we brings to you another classified bunch of faculty who will be discussing upon a testosterone as a molecule, its therapeutic application, and few case-based scenarios. So without wasting much of your time, let's welcome the faculty for today's webinar. This actually requires no introduction, but still I would like to call out few of their contribution in the field of sexual medicine. I'll just share my slide. So we have with us Dr. Rupin Shah sir. He is a senior consultant andrologist at Lilavati Hospital. He is a founder president of SASAM. He devised the Shah's prosthesis and the single-stage surgical sperm retrieval technique. He has been part of multiple conferences and live uploading workshops. With his pioneer work in the andrology, he has been inspired hundreds of doctors. Then we have Dr. Vasan, a senior consultant uroandrologist, a CEO of Ankur Hospital, Bangalore, a current president of SASAM, that is South Asian Society for the Sexual Medicine. He runs the fellowship in andrology and men's health under the Rajiv Gandhi University of Health Science, Bangalore. He is specialist in microsurgery and prosthetic urology, and he has been conducted multiple conferences and CMEs in andrology. Then we have Dr. Vineet Malhotra. He is a senior consultant uroandrologist, a clinical director at DOS Men's Health Center, New Delhi. He has a vast experience in the field of andrology. He has been invited as a guest speaker at many international and national conferences along with the live operating workshops. He is a specialist in microsurgery and prosthetic urology. Then we have Dr. Ranjit Ramaswamy. He is an associate professor of urology and director of reproductive medicine at University of Miami, Florida at USA, having more than 300 plus research publications, 13 books and many monographs. He has done a pioneering work on the role of nasal testosterone in preserving spermatogenesis. He's also been the part of ongoing RCT for PRP in ED, ongoing SWT trials in ED and stem cells. And recently, he also concluded the research on COVID in semen. Then we have Dr. V.S. Karthikeyan. He is a consultant urology, andrology, and men's health. He has been associated with Sri Narayani Hospital and Research Center, Vellore at Tamil Nadu. He has been the active member of IMS Standard Committee for the Men's Health. He has been the editor of Men's Health Society for India. He's also been having a more than 70 plus peer-reviewed publications in his back. Then we have Dr. Aditya Prakash Sharma. He is an assistant professor at Urology, PGR Chandigarh. He's also been the in charge of Men's Health Clinic at PGR Chandigarh, having more than 80 publications in peer-reviewed journals and 5 chapters in books. His special area of interest is male infertility, andrology, and uro-oncology. Recently, he also completed the study on SARS-CoV-2 in semen of COVID-19 men. And lastly, we have Dr. Raman Tanwar, a chief andrologist at Eurocenter India. He is a Secretary General of Men's Health Society of India. He is having a special area of interest, includes the penile prosthesis varicocele, and he also conducted the largest virtual men's health camp. And he has also been the part of many national and international conferences as a faculty. So I thanks all the faculty member for joining in. Now I request Dr. Karthikeyan. So please tell us more about the today's event and please take it ahead. Over to Dr. Karthikeyan.
Thank you, Dr. Sachin. Thank you everyone for logging on this event, and thank you all the speakers. Thank you, sirs, for coming here to give the enlightening knowledge about the testosterone basics and beyond. So I invite Dr. Rupin Shah sir and Dr. Vasan sir to chair the first session and invite the speakers for the 2 lectures. Over to Rupin sir and Vasan sir. Thank you.
So actually, I must start by congratulating you for organizing this symposium. There are many areas in andrology where the answers are not very clear-cut, and that might show up in this discussion today, where members of the faculty may have differing views, and it's very important for us to hear these views so that we form our own approach. So it's a wonderful thing you're doing. I hope you continue with many more such seminars. You've gathered together a wonderful faculty. My special thanks to Ranjit. There's no area in andrology where Ranjit doesn't have either a paper or a meta-analysis or is not involved in doing an RCT. So he's truly one of the people that we're very proud of. Since I'm old enough to say he's quite young, and I'll call him the young star of the future, but actually he's quite very, very senior now already, and his work is amazing. And it's always a pleasure to have him as part of our faculty. So with this, I'll hand it over to Vasan to actually introduce the speakers of the first session.
Good evening. I think, can I have the slide? There is slide. I guess Vineet is going to speak in the first session. Yeah. So, good evening. I think Vineet needs no introduction. I think he was just now introduced, and I think he's going to set the ball rolling by discussing about the prescription, the preparation, and follow-up of PRT or testosterone replacement therapy. I think this is a very important area. Like Rupin said, there's a lot of controversy in this area, and it would be nice to hear Vineet, who does an extensive research in any of his presentations, and learn a lot from him. Over to you, Vineet.
Sir, you are in mute.
Thank you, Vasan sir, and thank you, Rupin sir, for the kind introduction. Thank you, Karthik, for this invitation. This is as Rupin sir mentioned, this is an excellent fiesta today, because I think you've picked up the topics that need discussion, And you've got the faculty on board, having Dr. Rupin, Dr. Vasan, and Ranjit on board. So I think we are headed for some interesting discussions. Let's quickly begin with the next slide. And there's a lot of controversy with testosterone replacement therapy. You know, we know about the use and abuse of it. It's been used for gym trainers, use it for bodybuilding for their clients. Older men use it for general fatigue. Younger men use it for general fatigue. Erectile dysfunction is where it is used and abused very frequently. A lot of young men come to us asking us whether they can take replacement therapy to improve their penile or genital size, and unfortunately still used very often for treatment of male subfertility. So today what we're looking at answering is, when should you use testosterone replacement? At what levels of serum testosterone would it be appropriate to consider it? How long would you use it for? How would you monitor the therapy? Is it safe to use it? This is one of the main challenges. So and there's been a lot of study which has indicated that one of the main reasons why physicians do not use testosterone replacement therapy is the fear of introducing new cancer prostate, also increasing cardiovascular risk. Is it reasonable? Is it actually sensible? Is it useful for men with erectile dysfunction? Which of the formulations available is the best one to use? Before we begin with that, we must understand that the symptomatology of testosterone deficiency is very vague. So a lot of these symptoms will be non-specific. So you'll have symptoms of tiredness, weakness, reduced energy, low self-confidence. Understanding that a higher testosterone is actually going to boost up all of these things. So we have a questionnaire which actually deals with this. It's called the Adam questionnaire, which includes these 10 questions, and question 1 and 7, if you've answered yes to them, which means if there is a reduction in libido, or if the erection quality is less strong, or if you have any other of the 3 questions answered in the affirmative, it indicates that there may be testosterone deficiency. And there's an actual algorithm for it, but getting to the important part of this algorithm is that it must be tested on 2 occasions. Morning samples are preferable. They can be fasting, and especially in older men, you would really prefer them to be fasting. So you would have 2 confirmatory levels that have been done. Then the differentiation of whether you're dealing with a primary hypogonadism or a secondary hypogonadism, and rule out other causes. So meanwhile, if you're dealing with other factors such as obesity, liver dysfunction, diabetes, aging, and you're looking at someone being affected with his SHBG levels, and hence the testosterone looking erroneously low, you got to rule that out. So diagnostic recommendations are testosterone deficiency having characteristic set of symptoms, of which the sexual symptoms often predominate, especially reduction in libido. Total threshold value of 350 nanograms or less. Actually, you can be a little conservative. I'll come to that when we come to practical tips, but that's one of the guidelines. And clinical presentation may aid diagnosis. Rigid application of diagnostic thresholds based on total T values is discouraged. You must also consider testing men that have a high risk factor for having low testosterone, those with sexual dysfunction, type 2 diabetes, metabolic syndrome, obesity, pituitary mass, treatments that suppress testosterone levels such as chronic corticosteroid therapy, and other things such as man presenting with infertility, HIV, and others. Lab evaluation will include measuring testosterone between 8 to 10, 8 to 11 a.m., preferably in the fasting state, 2 levels to strengthen the lab assessment, and knowing where suspected or known abnormal SHBG levels as mentioned. Perform hematological, cardiovascular, breast, and prostatic assessment before starting therapy. We'll discuss that in greater detail. Assess for cardiovascular risk factors before starting testosterone treatment, and optimize secondary prevention in men with pre-existing cardiovascular disease. So what are the indications for testosterone replacement therapy? Delayed puberty, Klinefelter syndrome with hypogonadism, sexual dysfunction. This is where we are not dealing with fertility as an indication. We'll talk about when fertility is an indication, testosterone replacement therapy is actually not considered at all. Sexual dysfunction and low testosterone not responding to PD5 inhibitors, low bone mass in hypogonadism, adult men with low testosterone, and consistent and preferably multiple signs and symptoms of hypogonadism, hypopituitarism. So what would be the tests that you would do before you would start replacement? A digital rectal examination is recommended. In fact, that forms a part of a protocol that is even in the follow-up. A complete blood count, including hematocrit. Hematocrit forms the most important pre and post-operative follow-up following testosterone replacement, as this is going to rise once you start the testosterone replacement. LFT, especially if you're considering giving oral testosterone therapy, then you've got to do the liver function tests. A PSA, again, we'll discuss what the risk of cancer prostate actually is in men that receive replacement therapy, and prostatic symptoms, because lower urinary tract symptoms may sometimes worsen for men that receive testosterone replacement therapy. And what are the contraindications? So if you have active locally advanced or metastatic disease, that may be a contraindication. Male breast cancer will be a contraindication. Men with active, as mentioned, fertility desire would be an active contraindication. A hematocrit, baseline hematocrit of more than 54% would be a contraindication, and severe chronic cardiac failure or having edema, congestive cardiac failure before at baseline before treatment is started. So it should not be used in men more than 65 years. For general fatigue, severe untreated obstructed sleep apnea, severe low tract symptoms, recent MI or stroke within 6 months, hypercoagulable states, or to control sugars in diabetics. This is not a oral anti-diabetic treatment. We must inform the patient about the expected benefits and side effects of treatment options, select the preparation as an informed decision with the patient. And we usually begin with short acting agents initially, see the response, and then move to the longer acting. In this way, we've seen not only the dosage requirement, the interval requirement, but also the tolerability of the patient and whether there are any adverse events or not. Do not use it in men with male. This will come again and again. I've kind of hammered this into this talk that you will not use it for fertility treatment. And this is where you will use HCG. In patients with adult onset hypogonadism, only prescribe testosterone treatment in men with multiple symptoms. And if general measures have not worked, which means you've looked at lifestyle modification, control of diabetes, obesity, weight loss, good treatment, all of that is proved unsuccessful, and then you move to this. So what are the formulations that we are looking at now? So commonly what we would start would be either a short acting testosterone enanthiate or cypionate, or a transdermal gel, and then look at moving to the long acting esters such as the undecanate. Now, we don't have the pellets available in India, so those are not a choice for us. But we'll usually begin. So in my practice, I tend to start with either the gel or the short acting agent. And these we know are given every other week, which means every 2 weeks in a dose of 150 to 200 milligrams. And the problem with them is that you'll get a supraphysiological response, and then they will gradually go into the hypogonadal range. It is intramuscular, it's every 2 weeks, so that's a little bit of a disadvantage when compared to the long acting esters, which you can shift to, which then you require to give only once in 4 months. The gels, on the other hand, require daily dosage, but if used appropriately, a lot of men will prefer that because they don't need to get injected. So, and they have not this peak and trough that you get with the short acting agents. You get this more physiological range in the male, which for both serum testosterone and E2 occurs without these fluctuations. So it provides flexibility of dosing, ease of application, good skin tolerability, and there is less erythrocytes. So you're going to look at less requirement of, that peak of the hematocrit, that fluctuation. That's not going to happen so easily. But one of the clear instructions to the patients is they're going to make sure that they're going to wash it off after a few hours of application, they have to make sure that there's no physical contact with their partner or with the child, because otherwise there is direct skin to skin transfer, and that may have its own clinical significance. Also available as, I think, nasal formulations will be spoken about by Ranjit, I believe, and the newer advances. So the pellets are not available, but if you have the pellets, then the pellet contains 600 to 1200 milligrams implanted subcutaneously with peaks at 1 month and sustained for 3 to 6 months. So actually a very, very comfortable device for the patient, because it requires infrequent administration, but it requires a surgical procedure. Rarely it may extrude or cause a local hematoma or infection, but actually a very useful technique. What we use actually is long-acting undecanate. Now, one of the problems is it's an oil, and I know my patients actually remember the day that they have to come, because they have this painful butt injection that they have to come for every 3 months. But the usefulness of it is that it's a injection that they require once in 4 months only, infrequent administration, and the physiological range of the peak and trough is fairly decent compared to the short acting agents, and so a lot of patients do not actually have those severe rises in hematocrit that you would see otherwise with the short acting agents. But it's a 4 ml injection, and 4 ml of oil injection is a very painful injection. So the side effects include erythrocytosis, acne, oily skin, detection of, now we'll talk about subclinical prostate cancer, growth of locally advanced or metastatic prostate cancer, reduced sperm production and fertility, especially in a man that's come to you for treatment of fertility. And there may be local reactions also, which means with the local gels, you may see some skin reactions at the site. You may see transfer from one partner to another. With the intramuscular injections, pain is one of the features with it, fluctuation in mood or libido. As mentioned with the pellets, you may have infection or expulsion. And with the nasal gel, rhinorrhea, epistaxis, nasal discomfort, nasal congestion. We don't use oral tablets very frequently because of the amount of fat that needs to be ingested, the fatty meal that needs to be ingested along with to allow absorption of the oral tablet. So it's very infrequently that we see use of oral testosterone tablets for treatment of LOH. Now we'll discuss a little bit about TRT and cancer prostate, and a lot changed from with our concept to the risk that TRT would pose in terms of causing cancer prostate, because of the theory introduced by Morgenthaler, which spoke about saturation. So prostate tissue sensitive to changes in androgens at low concentration, but stops to respond after reaching saturation levels. And they found that once it's reached a level of 250 nanogram per deciliter, then these androgen receptor sites are all completely filled, and then you don't have any further response from the prostatic tissue, and hence no risk of actually inducing prostatic malignancy de novo, which means which is not already existing. This is not greater than the general population. So TRT does not increase risk of cancer prostate in men with a normal DRE or where the baseline PSA is below 3 nanograms per deciliter. It's not used in men with active disease, elevated PSA, abnormal DRE, or within a year of treatment, or before PSA has reached nadir levels, which in case of radiotherapy, brachytherapy can be less than 1 nanogram per deciliter. And it may be used in hypogonadal men with low-grade localized disease. This is controversial, and maybe we'll have some discussion on this later on. For cardiovascular disease, again, the weight of evidence indicates TRT is not associated with increased cardiovascular risk. Number of studies indicate that it actually may provide cardiovascular benefits. So there's actually a controversy there, and improves the number of metabolic parameters associated with increased cardiovascular risk, such as fat mass, dyslipidemia, and insulin resistance. The thing is that you would not give it to someone who has actual congestive cardiac failure or edema. So you would be cautious in such patients, but otherwise it does not increase risk of cardiovascular disease. What about erectile dysfunction? Again, it's useful where men already have low libido and erectile dysfunction. This we've spoken about. It's a useful adjunct with PDE5 inhibitors or as monotherapy where PDE5 inhibitors are either not working or are poorly tolerated. So yes, an important agent to treat men with erectile dysfunction, but there are indications of where it may be actually useful. How would you follow up? Total testosterone and hematocrit are the most important. We've got to reach mid-normal range for testosterone and keep the hematocrit less than 54. I have a lot of patients that actually donate blood every time before their next dose of testosterone injections, because otherwise they would reach target hematocrit levels. So venesection or blood transfusion is a simple way of then managing these patients. PSA, which is less than 4 nanograms per deciliter or at baseline, or a rise of PSA less than 1 nanograms is considered safe, and absence of abnormality on DRE. So the aim is to raise concentrations into mid-normal range. With the injections, we measure the testosterone concentrations, the short-acting injections, midway between the injections. So we would consider the mid-interval to be between 400 to 600. That's the dosage that we want. That's the range that we want to maintain as a mid-normal range, right in the middle of when the next injection is due. For the gels, you need to assess T concentrations 2 to 8 hours following the gel application. And that too, when this treatment has at least been on for a week. And then you can, again, keep this range in the mid-normal range levels. For the injectable long-acting agents, testosterone and echinate, we want to measure this just before the next injection is due. So normally, again, how do you do that? We usually will test the first time between the 8 to 12 week interval, because we know this is where it might reach another levels. And this is where we measure both total testosterone and the hematocrit. And then again, try to maintain this at the mid-normal level range or the low mid range. Here we are, because we are at the end of the injection, we could actually be between 350 to 450 also. So assess the response to testosterone treatment at 3, 6, 12 months and thereafter annually, because you would have reached a dose calculation. Monitor testosterone hematocrit at 3, 6, 12 months and thereafter annually. Reduce the testosterone dosage or switch preparation from intramuscular to topical, or allow venesection blood transfusion if hematocrit crosses 54%. If it remains elevated, then you need to stop it, reintroduce at a lower dose. Assess prostatic health by digital rectal examination and PSA before the start of therapy, and follow up PSAs at 3, 6, and 12 months and annually thereafter. And treat men with hypogonadism and either pre-existing cardiovascular disease, venous thromboembolism, or chronic cardiac failure who require testosterone treatment with caution. You would be very, very cautious in such patients. So quick recap of what we've learned. LOH, the symptoms can be non-specific. Use the questionnaire. Be conservative on your blood levels. Make sure you've measured them twice, ruled out any abnormal SHBG elevations or lower SHBG levels before you've initiated replacement therapy. It does not increase cancer, prostate, and hypogonadal men who do not have risk factors. Initiate therapy with a short-acting agent, switch to a longer-acting agent after the dose, interval, and safety has been assessed. Monitor as per follow-up protocols depending on formulations used, and avoid testosterone preparations when fertility is considered. Thank you so much for your kind attention.
Thank you, Vineet, for that excellent summation. I think we'll follow up lecture with Dr. Ranjit, and I think Rupin can introduce Ranjit. You're on mute, Rupin.
Yeah. Who's the next speaker, Vasan? I don't have the
Ranjit.
Ranjit, what is Ranjit talking on?
Recent advances in testosterone therapy.
So, see, it's a pleasure to introduce Ranjit. Actually, I already introduced him earlier. I've met him many, many times across many meetings. He's always very open, very interested in new things, and most important, he's a prolific writer. He worked with Peter Schlegel and Cornell, and more than half of Peter's papers were written by him. And some of the most quoted papers, including one of the top 25 papers that Fertile Sterile put out in a special issue, were authored by him. So he's been remarkably prolific, and now that he's moved to Miami, where he's professor of andrology, he's been training a whole new crop of andrologists, writing meta-analysis and systematic reviews on every topic related to andrology, conducting surveys, as you saw in his slide, in all the latest cutting-edge areas, PRP, stem cells, low-intensity shockwave therapy, and the rest. So it's always a pleasure to listen to him. And one of the areas where, since several years, he's been doing work is nasal testosterone, which, as he will tell you, is able to restore testosterone levels without suppressing the HPT axis, which is the major concern that we have. So Ranjit, over to you.
Thanks, Rupin, and thanks, Karthik, for organizing this. And this is obviously a great forum. I wouldn't say yes to a Sunday morning talk if it weren't for these wonderful people here. So we'll get started. I was given exactly 12 minutes to discuss the most advances in T therapy. So I won't dwell on a lot of the basic concepts, but really try and stress just two very important concepts that we'll touch upon today. First, I want to stress upon something called a serum 17-hydroxyprogesterone. This is a blood test, which is basically a metabolite in the cholesterol metabolism. This is cholesterol here, and this is aldosterone, testosterone, and cortisol. Is basically cholesterol metabolism pathway, and this is just one of the metabolites. We actually first showed that in a case report that it can be used as a serum biomarker in men with hypogonadotropic hypogonadism. A lot of what we're going to talk about today is medical therapy for infertility, and we try to assess what's going on inside the testis, and we found out that this could be one of a good serum test that we can order to evaluate what's happening inside the testis. Where did this idea come from? In 2008, a contraceptive study was done out of the University of Washington in Seattle, where they evaluated testosterone from testicular biopsies obtained from men who were given HCG. And they found out there was a beautiful correlation with serum 17-hydroxyprogesterone, showing that as the testosterone levels inside the testis went up on biopsies, the serum 17-hydroxyprogesterone also went up. So first time we have something to tell us what's happening inside the testis other than just serum testosterone, as we know from Vineet stock that can be so variable and with such a normal range that is so broad. Then we published this in Journal of Urology last year, basically showing that 17-OHP will actually go down in men taking exogenous testosterone therapy. The yellow bars basically show testosterone therapy, like all of the ones that Vineet spoke about, and clomiphene citrate and or HCG in the green bars. So 17-hydroxyprogesterone is on the y-axis. You see here that the 17-OHP will go down when you take exogenous testosterone therapy. That makes sense. That's what blocks intratesticular testosterone when you give testosterone from the outside, as opposed to Clomid and HCG, which will actually increase endogenous production of testosterone inside the testis to show that it goes up. So finally, we have some sort of a good biomarker that we can just evaluate with a simple blood test, telling us what happens inside the testis. Then we wanted to answer the question, is there any marker that we can use to tell us who will respond better to therapy? We give Clomid, HCG, anastrozole, Arimidex, letrozole to all these patients who come into us for infertility, and they ask us the question, Doc, what are the chances my sperm count is going to improve? We don't know that. We just take the pill, pray, come back in 3 months, we'll see what happens. And so I think we found out that a serum 17-hydroxyprogesterone of less than 55 nanogram per deciliter actually predicts a much better response to medical therapy. Makes sense. If you have lower intratesticular testosterone, then the chance of you improving intratesticular testosterone and therefore spermatogenesis will be higher. So less than 55 17-OHP appears to be a good biomarker of response to medical therapy for infertility, either with Clomid, HCG, and or with anastrozole. Testosterone, for all practical purposes, is a contraceptive. It is in the guidelines. Like Vineet spoke about, exogenous testosterone therapy should not be used in men with infertility. You can use HCG monotherapy in men who are trying and who have normal T levels, but really testosterone therapy should be considered as a contraceptive. However, some recent research that we have done basically shows that maybe this is not true for all testosterone therapies. And we first did a systematic review, basically, which showed that maybe shorter acting testosterone therapy with the nasal gel, with the daily gels, compared to these long acting injections, some given over 2 weeks, some were given over 8 weeks, maybe they will have a lesser effect on gonadotropins, FSH and LH. And so we first showed that the shorter acting therapy will actually have a lesser effect on FSH and LH compared to long acting testosterone therapy. And this was one of our first clues that said, maybe there is a difference even among the different testosterone preparations. And in an animal study, we actually showed that if you gave testosterone propionate to animals, they will have a much lesser effect compared to these long-acting testosterone pellets. So male mice, when are given testosterone propionate, can reproduce faster and better compared to male mice that are given testosterone pellets. So again, more clues telling us that short-acting testosterone is somehow better for maintaining reproduction than long-acting testosterone therapy. So then we went on to do a clinical trial using the nasal testosterone gel. There's nothing fancy about the nasal gel or its preparation, but except the fact that it's short acting. I think we swung the pendulum too far for both physician convenience, patient convenience, and compliance to make testosterone therapy longer and longer acting. Back in the 1950s, all that we had was testosterone propionate, which was given every other day. And now we went on to testosterone injections, Nebido and testosterone undecanoate, which is given every 3 months sometime, and these testosterone pellets, which are given every 4 to 5 months. But nasal gel is very short acting, and it only lasts for about an hour peak and basically goes down in the next 2 to 3 hours. So we did a pilot phase 4 trial at the University of Miami to see if it maintains spermatogenesis. We only included men who had a total motile sperm count of greater than 5 million with a low testosterone level in the morning, and we excluded men who were taking previous testosterone therapy. And the results were very interesting. First, we saw that the testosterone levels went up at 1 month, 3 months, and 6 months. And we saw that the FSH and the LH levels actually went down. So they did not become undetectable. So most exogenous testosterone therapy, you'll see the FSH and LH become almost 0 to none. But here with the nasal gel, we actually showed that the FSH and LH were decreased, meaning that there is some impact on the GnRH and FSH, LH, and on the HPG axis, but certainly does not abrogate the production of FSH and LH. And probably the most interesting result was seen here, where we saw that the sperm count was maintained in 95% of the men that took testo or nasal testosterone gel. So very interesting data to show that in most other exogenous testosterone therapy trials, you'll see that 65% of men will actually become azoospermic at 3 to 6 months. But here we see that most of the men are maintained. And certainly, yes, we do see a decline, but this decline doesn't continue to decline. We do have 12-month data to show that people who maintain end up maintaining it. A very few small group of patients, about 5 to 10% that become azoospermic, recover almost immediately because of its short-acting effect. So does this impact of nasal testosterone gel have any more effects than just fertility? Vineet spoke about polycythemia as one of the side effects of testosterone therapy. And I think basically trying to maintain the HPG axis, trying to keep the body more physiologic, trying to completely abrogate the HPG axis with long-acting testosterone therapy, I think has more influences than just fertility. Here's a nice study where we showed testosterone cypionate compared to nasal gel, and we found that the incidence of polycythemia was much higher in the testosterone cypionate men, and the men that took testosterone cypionate compared to those that took nasal testosterone gel. Again, maybe fertility is just one of the beneficial effects, but maybe the short-acting testosterone therapies will have a better effect on having some of the side effects compared to long-acting testosterone therapies. So now we actually have a randomized trial ongoing at the University of Miami, comparing nasal testosterone gel versus testosterone cypionate. It's a 1-to-1 trial. We're looking at data at 4 months, trying to see if the prevalence of polycythemia with hematocrit will be much higher with testosterone cypionate compared to testo, Obviously, we're looking at some of the other side effects with estrogen, DHT, as well as PSA, to try and see maybe there is more benefits to the short-acting testosterone therapy compared to the long-acting preparations. I know we spoke about the challenges of oral testosterone in the United States. Finally, we have an oral testosterone tablet called Jatenzo. This is absorbed through the lymphatic system as opposed to the circulating blood supply, with bypassing the first pass metabolism with the methyl testosterone that used to be there. But finally, we now have testosterone undecanoate with much better results. This is very new. We're trying to see if we can do a study with this. We're actually doing a study with this, and hopefully we'll have some more data for you guys in the future. Obviously, we've done work, and we are continuing to work on stem cells, just as is common in most other specialties in medicine. I think hypogonadism and testosterone therapy certainly lends itself to stem cell therapy, because this is something that, especially if men are affected at a very young age, will need this for a long term, and trying to be on medications for the rest of your life, especially in young kids with Klinefelter syndrome, Kallmann syndrome, and so on, not such a great idea. So hopefully in the future, we'll have some more work on stem cells that can help this population. And with that, I'd like to conclude and thank you for the opportunity, and obviously look forward to all of the cases today, and thank you.
Thank you so much, Ranjit sir. With this, we conclude this session and we move to the second session, which is the case discussion. And now I would like to invite all the esteemed panelists, Dr. Rupin Shah, Dr. Vasan, Dr. Vineet, and Dr. Ramasamy. And the first case will be presented by Dr. Karthikeyan. Over to you, Karthik.
So thank you, sir. So we are going into the case discussions. The first discussion will be revolving around testosterone and infertility. So I will invite, I'm going to introduce the first case, and I will request Dr. Vineet sir to take up the first question which will come up. So introducing the case, a 5-year primary infertility couple. The husband is 34 years and the wife is 26. Since the wife evaluation is normal and there was a low sperm count on evaluation, the couple was referred to a urologist. So on examination, the BMI was on the higher side, 28 kilograms per meter square, with reduced facial and pubic hair and obesity. Bilateral, the testes were 8 cc and epidermis and vas were normal. And on semen analysis on 2 different occasions, the reports were 0.5 million per ml and 1.1 million per ml. So Vineet sir, like what is the next logical step we'll be doing in this couple?
So you're looking at this man who's hypogonadal, obese, and I would obviously want to differentiate between primary and secondary hypogonadism and look at an endocrine profile for him.
So what are the tests which we order under the endocrinological evaluation for low sperm count?
I would look at total testosterone, FSH, LH, and an estradiol, along with a prolactin level. All right, so we have these. So the LH is 0.6, which is below range. FSH is 1.1, which is below range. As total testosterone is also low. Estradiol is in range. Prolactin is marginal, which is not significant. So this is, we're dealing with hypogonadotropic hypogonadism.
Okay, sir. So next we will like to discuss about bioavailable testosterone and invite Dr. Ranjit sir to take up this question. Sir, what is bioavailable testosterone and what is the difference between estimated and calculated bioavailable testosterone?
So I don't routinely use bioavailable testosterone, but bioavailable testosterone is basically the combination of free testosterone and testosterone that is bound to albumin. And normally it is around 160 depending nanogram per deciliter. And so testosterone is bound to sex hormone binding globulin, which is the bound fraction. Some of it is bound to albumin, and some of it is free. Free is around 2%. What binds to albumin is around 30 to 35%, and what binds to sex hormone binding globulin is around 60 to 65%. If it is bound to sex hormone binding globulin, that testosterone is not available to be seen in the to the tissues. So really what is bound to albumin, which is loosely bound, and whatever is free is what is available. Now, when you evaluate between free testosterone, which is estimated versus calculated, very few laboratories in the world are actually able to do calculation or estimate the free testosterone because of its very short half-life with liquid chromatography mass spec. Most of the time it gets calculated based on a formula with age and SHBG. So that's what is done. I'm not a big fan of using free testosterone or bioavailable testosterone. As long as the total testosterone is less than 300, you just base your treatment based on serum T. If the testosterone is in the range between 300 to 400 and men are complaining of symptoms, then I look at free T levels. And if the free T levels are low, then you can think about treating that guy with testosterone therapy.
Okay, sir. So before going on to the in-depth discussion about treatment, so this is a very favorite area of very favorite concept of Dr. Ranjit sir. So I request you to explain to the audience like what is the HPG axis and how we use it in the treatment of hypogonadism and infertility.
So GnRH basically gets produced by the hypothalamus. This is a gonadotropin releasing hormone. It has very short half-life, and it is released in a pulsatile fashion. All of these neurons that go from the hypothalamus to the pituitary need to be intact. And in the case that you presented just now with hypogonadotropic hypogonadism, that's usually the problem where the connection between the hypothalamus and the pituitary gland is missing. And they act on the anterior pituitary gland to make LH and FSH. And LH, L stands for L acts on the Leydig cells inside the testis to make intratesticular testosterone. So we spoke a lot about 17-OHP and testosterone that's made inside the testis. The LH needs to act on the Leydig cells to make testosterone inside the testis, and that's what is intratesticular testosterone. And the FSH, S stands for S, supports spermatogenesis, and Sertoli cells for spermatogenesis. The inhibin that's produced by the Sertoli cells can negatively feedback, but most of the negative feedback is from the testosterone that gets converted to estrogen with the aromatase. Aromatase is actually present both in the Leydig cells as well as in the periphery to feedback negatively on the hypothalamus and the pituitary gland. So basically that's in a nutshell. For those of you that want to treat men with infertility with medications, understanding this basic concept is extremely important.
Thank you, sir. So moving on to prolactin. So what is the significance of serum prolactin, sir? We have just discussed the prolactin level in this case also. So when do we do prolactin?
So 2 times, I think if you look at the AUA guidelines, if the LH levels are low and the testosterone levels are low, getting a prolactin is completely reasonable. Now, prolactin, what to do with prolactin, I think is another big question. So I think I answered that question, right? So when do we do serum prolactin levels? So if the testosterone levels low, meaning less than 300, and the LH is low, so when there is secondary hypogonadism, then certainly trying to do prolactin level is a good idea. When do we investigate further? I think that's an important question. If the prolactin level is more than 25, then I would think about just treating the patient with cabergoline 0.25 milligram twice a week. If the prolactin level is greater than 50, then you should think about getting an MRI because you're thinking about evaluating for a pituitary microadenoma or a prolactin level. And I think I just answered your question. So when to treat, if the prolactin level is greater than 25, I usually just start treatment. If the prolactin level is greater than 50, you can think about getting an MRI. That's a little unclear if it depending on financial and insurance resources. You can wait up to 100 and 200 nanogram per deciliter of prolactin to get the MRI. But treatment with cabergoline, that is pretty inexpensive. And that you can start if it's above 25 or 50. There's no correct or guidelines go back and forth on which level to do it. I don't think there is a correct or wrong answer in treating patients with cabergoline for high prolactin levels.
So going to Vinit, sir. Sir, since this contains this disorder which involves almost all the anterior pituitary hormones, what is the role of thyroid function tests when we look at a case of hypogonadotrophic hypogonadism?
So if you're looking at hyperprolactinemia in your tests, then you should consider thyroid function tests, because this is one indication where you can have primary hypothyroidism leading to hyperprolactinemia. And medical therapy versus surgical therapy will actually make sense. And just treating the hypothyroidism will actually correct both the hyperprolactinemia and the infertility or the hypogonadotropic hypogonadism.
Okay, sir. So the diagnosis in this case would be now severe oligosteroteratospasmia, that is probably due to hypogonadotropic hypogonadism, where the total testosterone is only 119 with the very low LH and FSH levels. So Ranjit sir, what are the other specific questions we need to ask when we have made a diagnosis of hypogonadotrophic hypogonadism?
I think you want to know if the patient has Kallmann syndrome, and Kallmann syndrome happens only in patients with anosmia. So you want to ask if there is smell, a sense of smell, and the one important thing you want to know is if this was all the way through puberty, right? You know, is this congenital hypo, or is this some sort of a new onset wherein there are visual changes, there is recent onset of headaches. You know, if there are any other new symptoms that has happened, then you think of suspecting something like a prolactin secreting tumor or a craniopharyngioma or some large pituitary mass that is compressing the FSH and the LH from not being produced. So you want to know the onset of symptoms. You want to know if this is congenital or when did it start, and if there are visual effects, and whether the patient can smell or not.
Okay. So going on to the treatment options, I would like to invite Dr. Vasan sir to tell us what are the treatment options which are available in this patient, hypogonadotrophic hypogonadism, and how do we choose those options?
As I said, you have to go back to the HPG axis, which I think Ranjit brilliantly described. I think you're looking at intratesticular increase, or one of the tests I would do is a 17-hydroxyprogesterone, as he emphasized, which may be a better marker of even treatment response in this kind of an individual. So since you're looking at increasing intratesticular testosterone, your options are, of course, either SERM, which is your selective estrogen receptor modulator, or an HCG. So you could, depending on what you want, I would use an HCG since the level is very low. Initially, it depends also on the testicular size in this given individual. So if the testicular size is good, then the choice falls between an HCG or a clomiphene citrate. Anastrozole is only indicated if the estradiol levels are more than 40, then you could use an anastrozole. So it's a combination of the physical finding in this given patient and looking at the laboratory values and looking at some sort of monitoring of the response, which is what I think brilliantly Ranjit has summarized, that maybe 17-hydroxyprogesterone could be a better.
Okay, sir. So going on to the specific options, Rupin sir. So when will we start human chorionic gonadotropin, and when do we add the HMG, sir?
So I'll just take a step back about which options which Vasan addressed. If a man had azoospermia with hypogonadotropic hypogonadism, then that would indicate a more severe degree, and he would probably be treated with HCG followed by HMG, which I'm going to talk about. In this case, however, the testis size is 8 ml, which is not small by hypogonadotropic hypogonadism standards, and he has 500,000 sperm counts, suggesting that there is partial responsivity. And some of these patients sometimes respond to oral medication, clomiphene or anastrozole, which is of course much cheaper and more convenient than HCG, HMG. So if he had been azoospermic, I would have gone straight for HCG. But since he has some sperm, I would start actually with a mixture of clomiphene and anastrozole. The reason why I would give anastrozole is that the TE ratio here is quite altered. Testosterone is only 111 and 19, and estradiol is 34, so the ratio is almost half. So I would initially give him a trial with clomiphene alternate days and alternating with anastrozole. And at 3 months, I would monitor the semen, the testes volume, and the testosterone level. I don't really think you need 17-hydroxyprogesterone here. Simple measurement of testosterone would be adequate. Hydroxyprogesterone becomes trickier when you think that the testosterone assay might be unreliable because of exogenous administration. If at 3 months he shows good benefit with the oral tablet, I would continue that. If he has not shown a rise in testosterone or a change in semen analysis, then I would start only HCG. HCG, the optimal dose would be 2000 units thrice a week, but HCG has a fairly long half-life, and practically speaking, many men respond to one shot of HCG 5000 every 5 days, which makes it easier for them to take the drug. So I would start with HCG 5000 once a week or once every 5 days. After 8 injections, monitor the testosterone level 4 to 5 days after the HCG and see if it has doubled. If it is, then I know he's responding. If he's responding to the HCG, every 2 months the testes would increase in size by 2 ml or so, and testosterone would reach mid-normal levels. If that is happening, I would continue the HCG till the testes reaches a size of 12 to 14 ml, and then I would add the HMG. Could you add the HMG right away? You could, but HMG is again very expensive and needs to be injected thrice a week. So if you first prime the testes to its maximum growth by giving HCG and then add the HMG, it will be more cost effective. Now this patient again has some sperm, so it's very likely that he will respond rapidly to HCG and you could add HMG after 4 months or so. Had he been azoospermic, I've had men where I've had to give HCG for 12 months or even longer, up to 2 years, before adding the HMG. Does recombinant FSH add anything? To my mind, no. I don't think it has any advantage when you're treating men. And how long to continue the injections? Again, it will depend on the case. In a case of acquired hypo, 4 to 6 months or 8 months is enough. In a case of partial hypo like this case, maybe 6 to 12 months would be enough. Had it been total hypo, and I've mentioned this in previous meetings, I've had men who've needed injections for up to 4 years before we had sperm appearing in the ejaculate.
So we are talking about clomiphene and anastrozole. So in this patient, if we are about to start clomiphene, we will start it together or we will give clomiphene, then see the reversal of ratio, then how is the ratio, and then add anastrozole.
I would give clomiphene 25 mg on Monday, Wednesday, Friday, and anastrozole 1 milligram on Tuesday, Thursday, Saturday, simultaneously.
Okay.
Sunday chutti.
Thank you, sir. So going to Vinith, sir. Sir, how does this anastrozole act? What exactly it does to the testosterone and estradiol levels?
So again, what we are seeing is that in this particular case, as we are seeing, the TE ratio, as mentioned by Dr. Rupan, is altered, and you have a total testosterone of 119 and an estradiol of 36. This is a ratio which is altered. You need to put in a aromatase inhibitor to prevent this peripheral conversion of testosterone to estradiol, and that is where you bring in the anastrozole and allow the testosterone level to rise. And you would never use testosterone supplementation. Exogenous testosterone we don't have enough time is actually going to result in the suppression of the GnRH and the LH, which will result in reduction.
Vinith, you're very soft. You need to come closer.
Which will result in
lowering
of the intratesticular testosterone and spermatogenesis.
If I can add something here, what Vinith said was you prevent the conversion of testosterone to estradiol. That is the first step. And how that helps is that, as Ranjit showed, estradiol is the feedback mechanism that causes the hypothalamus and pituitary to stop secreting FSH. So when you lower the estradiol, you raise the level of FSH intrinsically and thereby stimulate the testes. So it's not just raising the peripheral testosterone level, but also increasing the FSH-LH level. Anastrozole will also act on receptors in the testes itself, preventing aromatization and increasing intratesticular testosterone.
So going on to Rajit sir, how do we clinically assess a patient on gonadotropin therapy? What are the clinical examinations we do on follow-up, sir?
So I think so we assumed that we're going to give them gonadotropins instead of clomiphene or anastrozole. So I think trying to evaluate serum testosterone level at 3 months is a good idea. And like Rupin said, now we're doing 17-OHP on an academic purpose. So we're getting it on everybody to try to see who it's going to be useful in and who it doesn't. But I think it makes sense if the testosterone level is low and the patient claims that they're taking the gonadotropins like you asked them to take properly, then getting a serum 17-hydroxyprogesterone and seeing if there is testicular response is a reasonable idea. If the serum 17-OHP is low, then maybe increasing the gonadotropin dose is also a good idea. And I think those I would do. And you can probably get the hormones at 6 to 8 weeks, but wait every 3 months to get the sperm analysis.
The clinical
Ranjit, what dose of gonadotropin do you use?
I usually use 2,000 3 times a week, but I guess 5,000 once a week is recent data from from China showing that it's fairly similar to the 2,000 3 times a week of HCG.
So clinical assessment, as Sarah already, Rupin sir has already told, we will see the testicular volume improvement. Is there a role for digital rectal examination when we are on gonadotropins for azoospermia or oligospermia?
No, there's no role for DRE.
Okay, sir.
Now, I have a question to Rupin and Ranjit. When you have an 8cc testis with HCG, is it reasonable to expect it to grow to 12 to 14 size, 12 to 14 cc?
Oh, 8 ml testes and hypo, I'm very happy. That's the testes that will do well. The ones that bother me, and that's something I've not understood, is that we see some men with hypo whose testicular volume is only 1 to 2 ml. Those are the ones who don't improve with full doses of gonadotropin. And I think that hypo probably falls in 2 different groups. One which is hypo in combination with testicular failure. And those are the really tiny testes. And even with gonadotropins, I fail. And then there are the ones, if they're 8 ml, those usually grow very well. I'd be quite happy with it, 8 ml hypo.
No, my question was, Rupin, what is the yardstick of testicular volume improvement you would want in these patients to be reasonably comfortable that your path or your medication is working, other than assessment of testosterone?
So what I find is that the ones who respond, I follow them up every 2 months, and typically at 2 months, I would see an increase of 2 ml in testicular volume. That tells me they're responding, and I'll continue the HCG till they stop increasing any further. And that's when I add the HMG.
So is it an ml? Because a lot of earlier papers talk about 10% increase or a 15% increase in the testicular volume.
So if it's 10% of 8 ml, that would be up to 9 ml. If it's 15%, it's 9.5 ml. So means when I say 2 ml, you have to understand that you're measuring with a Prader orchidometer. You have an error of 1 bead up or down.
Yeah.
So your measurement error gives you what you should look for.
The one difference there is that I do is a testis exam is easy. Then you know it's somewhat, you could feel it, it's right there. If you have to struggle to find these testes, these 2 to 4 cc testes, then I usually just start with 8cg plus HMG. If you could find the testes and it's there, it's 8cc, 10cc, 12cc, then just give them HCG alone to begin with.
So Ranjit, follow-up question. In the really tiny testes, whom you treat with HCG, HMG, have you seen what I've seen, that some of them don't respond at all? And do you have any thoughts on that?
Yeah, no, they don't respond. And those are the patients that require, I think they may require a TESI at 6 to 9 months if things don't respond. But usually those are all the cases, Rupin, where the 17-OHP is very useful. The case report that we presented, the guy came into us with 2 cc testes and his 17-OHP was low. And we basically increased his HCG, we increased to 3,000 3 times a week. And we finally saw an improvement in 17-OHP, and we finally saw some sperm in the ejaculate. So those are all the tough cases where we can do the 17-OHP to get some sort of a clue on what the intratesticular testosterone is. Because even if you take them for a TESI, if their intratesticular testosterone is not adequate, you're not going to find spermatogenesis, even in hypo patients. And so I think that's why it's very important to make sure that you've reached an adequate level of intratesticular T before you take them for either a TESI, give up, or take them for a TESI, or continue longer to wait for sperm in the ejaculate.
And when you're saying do the 17-hydroxyprogesterone, was there a dissociation between the serum testosterone, which had not gone up, and only the 17-hydroxy went up?
That's correct, yes. The serum testosterone did not go up at all. 2cc testis, it kept remaining at 120, 150. But we saw that the 17-OHP, I think, went from like 35 to like 45 or something. It's in the paper. We knew that it was going up, so we were very optimistic, and we finally saw some sperm in the ejaculate. And this is very important. This is a very nice, this one basic science allusion that I will make. You know, we talk about how important FSH is for spermatogenesis. If you really take FSH receptor knockout mice, so you knock out FSH receptor, those mice are actually fertile. Whereas if you knock out LH receptor, the mice are infertile. So really interesting and important to note that yes, we need germ cells, yes, we need FSH, yes, we need supportive spermatogenesis, yes, we need Sertoli cells. But truly what is most critical for spermatogenesis, to complete spermatogenesis, is intratesticular testosterone and LH and T. And so these patients are the perfect model system to study how important testosterone is for spermatogenesis. And even with a very few germ cells, we can take them all the way to spermatogenesis as long as you have good endogenous production of T.
Is there a role for GnRH in these small testes, pulsatile GnRH?
I don't think so, Vasan. I mean, as long as you can adequately replace FSH and LH, I don't think GnRH is very useful. Because in order for GnRH to work, you need to make sure that that first of all, it's very expensive to give it pulsatile, to give it regularly, to put a pump in these patients. As long as they are compliant and use HMG and or recombinant FSH and HCG, I think that should suffice.
We have started doing 17-hydroxy. We find that there are a lot of time no correlation between testosterone and 17-hydroxyprogesterone. Is it what you have observed?
Yeah, we're trying to figure that out as well. Sometimes 17-OHP is very high, serum T is very low. Yeah. Sometimes we see the opposite. Serum T is like 450, 17-OHP is like 35. And then we ask them if they are cheating and taking exogenous T, and they tell us no. We still don't know everything. This is all that we need a next year conference to discuss that.
So in continuation with these discussions, how long do we have to continue for with these injections before the sperms will appear in the ejaculate? When the testis is around 8 cc and when it is 3 cc?
Rupen talked about 4 years. I think that's obviously one end of the spectrum. But in these patients, you should at least wait 1 year before you discuss surgical sperm retrieval.
So going on to sperm retrieval versus ejaculated sperm, Ranjit sir, when do we do cryopreservation of sperms in these patients?
So I think in hypo patients, if they are young, if they are adolescents, and their parents are interested in future fertility, you see sperm, you should absolutely freeze it. There is minimal downside to freezing sperm when you are young. And I think we discussed actually the second question on like when do we do surgical sperm retrieval? I think if you have inadequate intratesticular T and your serum T level is normal, and you've waited for 6 to 12 months and there is still no sperm, and fertility is of essence, whether it's a wife waiting to get pregnant, I think in 12 months, trying to think about surgical sperm retrieval is completely reasonable. Chance of success in these patients is actually very high because this is a primary central defect, right? It's a problem with the hypothalamus communicating with the pituitary, and hopefully it'll be so rare for me to imagine that both the hypothalamus pituitary is affected as well as there is a primary testicular failure going on at the same time. So hopefully this is secondary testicular failure. And so the chance of true surgical sperm retrieval success in these patients will be pretty high. And because it is pretty high, donor sperm, I think, usually does not come into the discussion in men with true hypo. However, I would recommend going down the path of doing the proper azoospermia workup with karyotype, Y chromosome microdeletion, making sure there's no genetic defects, and counseling them appropriately in that path. in that small event that they have both a primary testicular failure along with central pituitary gonadotropin failure.
I'd just like to add something here in Indian perspective. Ranjit, in my practice, 4 out of 5 patients with hypo cannot afford the gonadotropin therapy, even though it's so much cheaper in India. So I think a message for the Indian audience is that before you start a hypo patient on gonadotropins, explain to them the duration of therapy and the cost. Otherwise, very often the patient will take it for 6 months, 9 months, spend 40, 50,000 and then give up because they can't afford more or they don't have the time. So if they understand at the very onset what is required, many of them may opt because of financial reasons for donor.
Yeah, as a corollary, Ranjit, I just wanted to ask you a question. I see a lot of these boys referred to me who are 16, 15, going for chemo or radiation for some reason. And how do you deal with that situation? You offer cryopreserving the sperm in that kind of an instant. Many of them don't ejaculate, so you don't have an ejaculate. So what do you do for them?
So yeah, and a simple office testis biopsy to try and get sperm to is completely reasonable. I mean, it's a very different topic than what we're talking about today. We're talking about fertility preservation for adolescent boys undergoing chemotherapy. If they're going to undergo platinum-based cyclophosphamide, cisplatin, platinum-based chemotherapy, their chance of becoming azoospermic is close to 10 to 20% for the rest of their life. This may be their one small window where you do free sperm. And so if you have the ability to do, if they can ejaculate, obviously that's the easiest. If they cannot ejaculate, think about PVS, electroejaculation, and even simple testis biopsy to get sperm is completely reasonable. You don't need microtesting on these kids because this spermatogenesis is hopefully intact. This is not testicular cancer. This is some kind of other systemic malignancy that's causing, that they need to go on to get fertility preservation for. So yes, you should offer all of those things. You don't have a much big window to do it because chemotherapy is of essence and they're going to start that very soon. So try and do whatever is feasible and possible for you, the patient, what they can afford financially, insurance, and freeze the sperm in the rare event they become azoospermic.
If you don't find sperm in a routine biopsy or a TISA,
then give up. Then just say wait till you become an adult, and we'll worry about microtesting at that time. But that you tried everything in the best interest to obtain sperm, that's enough.
Thanks.
Sir, Vasan said, like when these patients come to you, how long do you wait and then proceed for surgical sperm retrieval? As Ranjit said, it is around 9 to 12 months. In our Indian population, what is the window for which we give HCG and HMG before we go for retrieval of sperms? Sir, you're muted, sir.
So I said it's a combination of factors. It's like Rupin said, first you have to counsel the patient on the reasonable time limit for which he's going to wait. It's also a combination of if they're looking for a baby, what is the female factor? What is the age of the female? What is the desire of this couple to have a baby? So it's a combination of factors. There's no hard and fast rule that each patient couple I would go through in the same way. There are couples who start the treatment with the hope that they will get the sperm early, and they also give up, like Rupin said, halfway through, and they would want to opt for another procedure to have a baby. So I would go ahead constantly discussing in each visit what has happened and what is the counseling. And I think counseling in this aspect plays a very important role. And it's basically the patient who decides as to how long he's going to wait. I have never seen a patient wait for 4 years. Rupin is very lucky to have that kind of patience, but generally 1 year is the time limit I would give them.
In fact, Vasan, that patient was very educated because at about 2.5 years when we didn't get sperm, he opted for a sperm retrieval. We did a single needle biopsy and we got sperm. At which point I told him we can now do IVF. He said, Doc, you've got a few sperm. I want to keep on trying for a natural pregnancy. And with that motivation, he continued the gonadotropin. Sperm appeared in the ejaculate somewhere after the 3rd year. And towards the end of the 4th year, his wife got pregnant naturally. So it was the patient's motivation that gave us the opportunity to see the whole biological process and evolution.
Absolutely. Like I said, that's why it's very important that you counsel them and allow them to make the informed choice.
So while we are on therapy for low sperm count with HCG and HMG, what are the blood tests which we do along with the clinical follow-up? Do we do testosterone alone, or we also have to do the LH, FSH, and estradiol?
I don't know whom you're asking, but you shouldn't do FSH and LH. It's a waste of money.
Okay, sir. So only it will be guided by the testosterone values.
Yeah.
And is there a role to add anastrozole on these patients? Do we do estradiol also? How do we do it, sir?
So, Ranjit, do you want to take that one?
No, I mean, if usually estradiol, I'm not a big fan of unless the estrogen goes up much higher in these patients. Then you can add anastrozole. But as long as the T2E ratio is normal, and usually in these guys it's okay, it's a 10-to-1 ratio, then I don't usually add anastrozole onto the gonadotropin.
Okay, the guys where I look at estradiol is if he's obese and on HCG his testosterone has not gone up to a level I like. Then I do look at estradiol, and not surprisingly in the obese hypo, often the estradiol TE ratio is altered, and there I will add anastrozole for some time.
I have, just to add to that, I think my experience is in oligospermia, which is what is this case. I've seen very little benefit when the estradiol is low, below 45 or 40, and the T ratio is altered. I have not seen much benefit adding anastrozole in that kind of a population. That's my assessment.
That's correct, Pastor.
And what is the maximum testosterone level which we are aiming at in these patients while we are on injections?
When you're on gonadotropins, I think greater than 300. I mean, I think that in itself is very good.
Okay, sir.
400 to 600, Ranjit. I mean,
target.
Yeah.
But sometimes with the 2cc, 4cc testis, Vasan, it's very difficult to get to 400 to 600.
Yeah.
So moving on to this couple who had a kid with the injections. Vineet, sir, is there a need for lifelong testosterone replacement in these patients?
Yeah, I mean, following the completion of fertility, depending on his total testosterone that remains, there will be, the requirement will be based on that. The fertility, for sure, we will try to complete the fertility in the first attempt itself, which means whether we are looking at using those sperms, cryopreserving, hoping that whichever way we've sorted for further fertility attempts also, you don't want to go back to again switching to the HCG, HMG expensive protocol for 6 to 12 months before you want to have fertility desire the second time around. So the first time around that you've actually taken this effort and you've gone through this, you've got sperm, you've got a successful first pregnancy, you make sure that you've stored enough for the next pregnancy also, and then shift to lifelong TRT based on his total testosterone.
If I can add something here, if the couple achieves a pregnancy the first time, say a natural pregnancy, and they say, doc, after 2-3 years, we may have another child, then I maintain them on HCG alone, not TRT, not HCG, HMG, but 5,000 units HCG once a week. That maintains testis size. Sometimes it's enough to maintain a few sperm in the ejaculate, and it's very easy then to get back to a good sperm count by adding HMG when they're ready for the second child. And in India, HCG 5,000 bought directly from the distributor would be about 200 rupees a week, which almost everyone can afford.
See, one of the challenges I've seen with that approach, Rupin, is, men with testosterone, especially when they are sexually active, and they feel much better than with HCG. If you're looking at fertility, I do agree that there is a difference in terms of fertility. So once the baby is done, they're also looking at active sexual life. And that's where I find a problem that many of them come back and complain that they have mild ED or ejaculate volume is low or the penis length is shrunk. And those are the problems I find if you're going to maintain them on HCG for 3 to 4 years before they consider a second child.
So Vasana, I'd add something to that. If you find that on HCG alone T is not maintained, which sometimes is, then I would suggest give them testosterone and HCG also, which is what the bodybuilders often do to protect the testes from the suppressive effect of the testosterone.
Sure.
So if there are no other questions in this, we will wind up this case here. Thank you, sirs, and I invite Dr. Aditya to start the second case.
So again,
so much, Karthik.
sorry, I'd just like to thank you for this case, because as the whole audience would realize, there was a fair bit of debate and discrepancy in our opinions. And it is this kind of a debate and discussion which is so critical in allowing the younger urologists, andrologists to form their own opinions and develop their own approach to their patients. So thank you once again for this case. Sorry, Aditya, please continue.
Thank you. Thank you all.
Thank you so much, sir. That is what everybody is glued to for this webinar. And that is why we are here to discuss the nuances. And we move to the next case. It is testosterone ED and prostate cancer. And without much ado, we'll move on with the case. So our patient is a 57-year-old gentleman who presented to us with erectile dysfunction, easy fatigability, and lower urinary tract symptoms. He's diabetic for last 15 years and he's hypertensive for past 5 years. And he is referred to us when we examined him, he is obese with a BMI of 31 kilogram per meter square. He's hypertensive, BP of over 190, 110 millimeter of mercury. The stretch penile length being 8 centimeter, bilateral testes being almost normal size. We did a rectal examination. The prostate was grade 2, firm and smooth. So my first question is to Vasan sir. What will be the next step in the outpatient setting? What we are going to do for this patient?
Sorry, I didn't follow this. I had a call. Sorry.
Sir, I'll just repeat the case.
I have a call. I will take this call. Can you ask somebody else?
Okay, no problem, sir. We can move to Rupin sir. Rupin sir, can you take that question?
You're referring to a urologist, in which case he goes to Vineet.
No.
Any of the panelists can take it, no problem, sir.
Right. So you have an obese man with erectile dysfunction. Yeah, can you just quickly? So obese man, hypertensive, 57,
and
and LUTS also, with a SPL of 8 centimeters. All right. Yeah. What's the next slide? Yeah. So he's essentially a obese diabetic. You're looking at a man who's got all features of metabolic syndrome. You're looking at obesity, diabetes, which is poorly controlled. You're looking at hypertension, which is uncontrolled. He's on medication, I believe, but he's uncontrolled. And he has low tract symptoms along with it. So we are going to look at first looking at his lifestyle factors in terms of controlling his diabetes, controlling his blood pressure, asking him to lose weight, and putting him on a PD5 inhibitor as an SOT to see for his response for erectile function.
So any particular investigations would you like to order for this patient?
So generally what we look at any man who's with metabolic syndrome at this age is, apart from his diabetic profile in detail, we're going to look at his cardiovascular profile also, not in terms of what a risk factor for PD5 therapy will be, but generally for his erectile dysfunction to be an indicator of his undergoing cardiac abnormality. Along with that, we do a lipid profile. I would do a testosterone total in this man because he's 57, he's older. We've seen certain features, though they may be because of his diabetes also, but I will tend to do that also. He has prostatic symptoms for which he will have evaluation of prostate, which means a digital rectal, a ultrasound with residual urine, PSA, and uroflowmetries.
So precisely, sir, we'll go with the following tests, and we get and Rupin sir, we just concentrate on the andrology part for time being, and we leave the lower urinary tract symptoms aside. How do we interpret these results, and any more tests if we need to order in this patient?
So obviously he is poorly controlled diabetes-wise. His testosterone is low, which would explain some of his symptoms, but I would not jump to explaining either his ED or his fatigability due to the low testosterone. So these men are very tricky. He's uncontrolled diabetes, hypertensive, obese. It's not surprising that he's fatigued easily. He has severe endothelial dysfunction. It's not surprising that he has poor erections. In such men, the question you may want to ask is that will testosterone replacement help or not? And I'm a bit of a skeptic. If he says that he has good libido, and often these guys will say, I feel the urge, but I'm not getting the erection, then I am reluctant to start him on testosterone at this stage. I would instead ask him to focus on a much better control of all the medical issues, add an alpha blocker for the LUTs, then monitor him over some period of time, give a PDE5 initially on demand, and then later on repeat the testosterone and then decide whether giving him TRT might help the other parameters.
Right, sir. So the message is loud and clear. We need to try all other methods before we move on to the TRT. So this is the EAU guidelines which say that you need to check symptom and sign, and as sir has mentioned that loss of libido is one of the very important factors. And that's how we go about, which has been discussed in detail by Vineet sir and Ranjit sir already. So we proceeded with the cardiac evaluation also. The ECG was normal, the echo pretty much was normal, showing ejection fraction of 55%. And we made a formulated diagnosis of a metabolic syndrome along with ED and a component of late onset hypogonadism or androgen deficiency in aging male. So now we have in the office itself, and he was initiated on lifestyle changes. So I would like to bring in Dr. Ranjit, and I would like to ask him what all lifestyle changes, because it's become a very important component when these patients come. And rather than writing a prescription, we offer them a lifestyle changes, a gamut of lifestyle changes. What are these changes which you counsel them in these patients?
So I think the basics, I mean, trying to lose weight, exercise, sleeping better, I think are all very, very important. Even if you're thinking about starting testosterone therapy in this guy, you have to tell him that you just can't take testosterone therapy and go to sleep and eat potato chips, because nothing is going to happen if you do all of that. And so I think it's very important to tell the patients that you've got to lose weight, whatever it takes. They'd be like, oh, can I do this diet? Can I eat this? Can I take this supplement? I mean, whatever it takes to lose the weight, and then exercise. And then obviously, I think we spoke a lot about controlling the blood sugar and blood pressure and so on, and try to get that under control and sleep better. And those are basic lifestyle modifications that we encourage. The one point that I will make is that, testosterone therapy on its own has been shown to improve fasting blood sugar, diabetes control, decrease in hemoglobin A1C, independent of using diabetic medications. So this whole concept of, yes, we should do lifestyle modification, but maybe a testosterone therapy trial for 3 to 6 months wouldn't be such a bad idea in this patient. Not long-term, but just to try to see if that'll help with both the diabetes as well as with some of his other hypogonadal symptoms.
So Ranjit, just to have you specify that very clearly. So this man, would you tell him that, okay, we'll implement you implement your lifestyle changes, but we are also giving you testosterone, and you would start him on TRT? Is that what you're saying?
That's correct. Yes. At 3 to 6 months, not long term, just to see him back in 3 to 6 months to see if things have improved.
And
if testosterone.
If things have improved, why will you not continue his testosterone?
Oh, 100% you will continue. If it doesn't improve, his blood sugar is still worse, his hemoglobin A1C is still high, his BMI hasn't gone down, his testosterone has mildly improved, and so then you would stop his testosterone. But if it has improved, 100% try and continue the testosterone.
So how do you differentiate? Does it mean, Ranjit, like Rupin is asking, all patients with uncontrolled diabetes and a little low testosterone, which you will find, and obese with metabolic syndrome, you would, as a corollary, find low testosterone in many of these men. Would they all be on testosterone replacement?
If they have symptoms, Vasan, I mean, if they are not complaining of low libido, low lack of energy, and not like little low normal, if it's less than 300, if it's like 250.
Just to interrupt, sorry. If in India, if you're in, most men of them are, we are not an athletic country. So, most of them are lethargic. If you ask them, any of them, what is your libido? Everybody will complain of low libido. If you ask them energy levels, everybody will say my energy levels is low. So it's a very difficult scenario for us in India. That's what I think Rupin is trying to get.
I'm speaking from America, which is one of the most obese countries in the world, right? So I don't think we need to talk about obesity as an epidemic anywhere. So it's become everywhere. So yes, I think so. So no, I think if patients come to us and they have this picture, giving them a trial of 3 to 6 months, telling them clearly that if they make the lifestyle changes, get their blood sugars under control, improve their hemoglobin A1C, and therefore their testosterone level in 3 to 6 months, I think giving them a course of testosterone therapy is absolutely reasonable. Only 50% of men with diabetes will actually have low T levels. So not every diabetic man that you see with metabolic syndrome is going to have low testosterone. And so, yeah, I'm totally okay with it. And with that caveat that this is not going to be long-term, you're not going to be on it forever. If they make the changes, I think it's completely reasonable.
Is this a recommendation? Sorry, Vasan, is this a recommendation that diabetologists are also following?
They are not, but now there is at least in the American Diabetic Association guidelines, there is guidelines to check serum testosterone levels in men with uncontrolled diabetes.
As a corollary, Ranjit, what is the risk of a cardiac event in these men who are already predisposed to this? Are we augmenting their, despite whatever Morgan Taylor's work and the contradictions what you have, is it going to be a risky, are you going to monitor them in cardiac way for an unfortunately?
So the whole concept of testosterone therapy and cardiovascular risk, we don't know what the underlying mechanism is. Is it polycythemia? We spoke about that a little bit. Vineet spoke about that as a possible risk factor for cardiac disease. Is it increased estrogen that causes fluid retention, hypertension, and cardiac risk? Or is it true atherosclerosis? Testosterone therapy causing atherosclerosis, causing cardiac disease and major adverse cardiovascular events? I think that association, Vasan, is very, very weak. So for you to say that diabetes is associated with cardiac disease and testosterone therapy causes cardiac disease because of diabetes, I think that association is very weak. We are still yet to prove a clear-cut association between testosterone and cardiovascular risk. And we definitely don't know what the mechanism of testosterone and cardiovascular risk is. And so I don't think the testosterone therapy is any higher risk of causing cardiovascular disease in diabetic versus non-diabetic men, just because I don't truly know the association, and I definitely don't know the mechanism of the association. If you tell me testosterone therapy causes atherosclerosis causing cardiac disease, then I will tell you giving it to diabetic men is riskier than non-diabetic men. But because we don't know the answer to that, I think we're okay.
So Ranjit,
my point is there an increased risk of dyslipidemia?
Increased risk of dyslipidemia in diabetic men after testosterone therapy?
Yes.
No, I think the only level that testosterone therapy changes, it may bring down HDL levels. But I think changes in total cholesterol and LDL, I don't think is seen with testosterone therapy. So as long as you monitor that and let them know, again, we're talking about a trial of 3 to 6 months, right? So if their blood sugar is controlled, their BMI is controlled, and their waist index goes down, all of you see parameters, improvements in all of those things, continuing it is a good idea. If not, stopping it is also an equally good idea.
So Ranjit, I think a lot of the audience is going to follow what you're saying today. So what would be your recommendation then? What is the man with what HbA1c and what testosterone that you would, with ED, initiate testosterone trial in?
So I think the case that was just presented with Aditya, I think is reasonable to do testosterone therapy. So first of all, you're going to ask the question, should we screen testosterone? Should we get a testosterone level in diabetic men? And I think if you look at the guidelines, the answer is yes, we should be evaluating testosterone levels in diabetic metabolic syndrome, obese men. And then if you look at the guidelines and ask, should we be giving testosterone therapy to men with diabetes? I think the answer is inconclusive, but I think giving it, that's what the guidelines say. but it's there in the guidelines to even talk about testosterone therapy in diabetic men with symptoms of hypogonadism. I think giving them a trial of 3 to 6 months with the caveat that all of their other parameters will improve, I think is reasonable.
Right. Thank you, sir. Let's move on with the case. And just off the track question to Vineet, sir. A lot of time you refer these patients to endocrinologists for maybe for sugar controls and other hormonal control. And a lot of time testosterone therapy started there itself. So what is your take on that?
Yeah, I rack my head why I've referred them to them in the first place. Yeah, that is a concern because you've not started with something in your mind. But now listening to Ranjit, this will be an interesting view, and I'll need to change my opinion also, because I would be reserved about starting testosterone replacement until unless, especially this is a man who has lower interact symptoms, and I would have a slight concern in my mind that his IPSS will change, his lutes will change, and I would have some reservation about introducing TRT here. And the first thing that the endocrinologist does that, and his sugars come into control, and his ED becomes better, and then I have nothing to talk about. Yeah, I mean, it is a relevant situation. I think seeing the current changes that might happen with the guidelines, it might be interesting to see. But currently, I don't recommend testosterone replacement at these levels right at the beginning of the first consult, because we'll start with PD5 inhibitors and then look at where they're responding, not responding, and then whether we're going to add a testosterone trial there or not, testosterone therapy there or not.
Okay.
Actually, in fact, when we were planning the cases, both of us had a doubt whether we should have an endocrinologist also on board in this discussion. So
I think
that
with
is
hemoglobin A1C of 9.8, having an internist or an endocrinologist is a very good idea. Unless I don't think as urologists, we are very comfortable with treating diabetes that is uncontrolled.
That's true, sir. So 3 months have passed and he still have easy fatigability, lower libido, and ED has still not improved. The next steps I would like to know from Vasan, sir.
Okay. So
What all options
in about half an hour? Will you be accessible?
What all options, treatment options for ED will you have in store for this patient on table at the second visit, after control of blood sugars and everything?
Yeah, I think one of the things I think Rupin already answered this at that point in time. I would always prefer a PD5 inhibitor because if you have instituted lifestyle changes and his comorbidity control is very good, then you're looking at a nitric oxide donor if necessary, or improving the PD5 pathway. And I would always look at a PD5 inhibitor. And the question is whether to start with a higher dose and then down titrate it, or start with a lower dose and up titrate it. I prefer to start with a lower dose and up titrate it. I think a lot of people in the West start with a higher dose and down titrate it. So that's a moot point. So I would always go with the PD5 inhibitor as a first line of option.
Right.
I would like maybe Vasan and Ranjit to comment on LIWST. I think it has no role in this case, but since you've put it up and both of them have experience with it, and the audience is always wondering about it, could Ranjit and Vasan comment on in which cases they would consider shockwave therapy? And in a case like this with obvious severe atherosclerosis, should the patient be even made to spend on it?
So I think in the trials that we have done, Rupin, it has only benefited in men with mild erectile dysfunction, people who have never tried a PD5 inhibitor, people who can actually have penetrative intercourse, but then just cannot last longer. I think those are the patients that would best benefit from shockwave therapy. If they are unable to get an erection, shockwave therapy will absolutely not help.
So absolutely no indication here.
No.
Yeah, I think the two ways we decide. One is if in a Doppler, we do routinely Doppler before we start shockwave therapy. If it shows arterial disease and then a significant arterial disease, those are men who will not benefit from shockwave. And we also do endothelial assessment. And if there is a normal Doppler with endothelial dysfunction, and we do a pulse wave velocity assessment, and pulse wave velocity assessment is normal, those are individuals who benefit. And usually, like Ranjit said, these are in mild to moderate category. They are never in the severe category of erectile dysfunction.
Intracavernosal injection, since you've put it up, I think very high likelihood that that is what would work rather than the PD5 inhibitor. So take home message for the audience watching. If you're going to be taking your level of andrology practice to the next level, you have to be using intracavernosal injections. A PD5 inhibitor, there's more than a 50-60% chance it's not going to work in this man. But there's a 50% chance that the intracavernosal injection may work. Not just pure papaverine, that won't work. Has to be a bimix or a trimix. Also, penile implant with an HbA1c of 9.5, I would not implant him. Ranjit and Vasan, what are your cutoffs for HbA1c before doing a penile implant?
8. It has to be less than 8.
8 for you. Yeah.
I luckily work with a diabetologist, and I have done cases with 9.5, 10, with just 2 days of managing. My diabetologist always tells me it doesn't matter, and he will control the diabetes. So I have seen, so far we have done about almost 15 cases with HbA1c of more than 10, and I don't see a higher infection rate in these individuals. But I guess it's also that I have the privilege of a diabetologist managing, not me managing myself the diabetes. So, and also there are some recent papers which have come out which do suggest that the HbA1c cutoff is not a sacrosanct thing for a penile.
Okay, but since we have an audience listening in, I think we still need to warn them to be cautious, because there's another large multi-center study that showed that after an HbA1c of 7.5, every rise in 1 point did increase the risk of infection. So your series is an impressive series, and I hope when it's a little larger, you would publish it, because it's an important question. I personally am very, very cautious. We can move on.
Right, sir. So we move on, sir. Dr. Vineet had partly discussed this part. So when to go for TRT in this patient? Specific to this, the diabetes is controlled, the blood pressures are controlled. We have added a PDE5 inhibitor. Still loss of libido and erectile dysfunction is persisting. So when all to go for TRT in such cases of late onset hypogonadism? Vasan sir and Robert.
Vineet, you want to take this because you have answered most of it.
Yeah. I mean, sir, my opinion is that if you've had a trial of PD5 inhibitors and you've gone through the gamut of PD5 inhibitors and you've not seen a response, you're seeing persistently low testosterone levels and the sugars remain on the higher side, I mean, that would be a plus factor for using TRT. But anyways, the TRT would then have its role because you're going to look at adjunct therapy with TRT. Even if you're looking at a response which is partial, the TRT would make sense here.
Right, sir. So now we have decided to start him on TRT. My question to Rupin sir, what is the preference of formulations which you use for these patients? And is there any difference if the patient comes at a younger age versus a patient who has come at the age of 57 or 67, let's say?
So right now we'll first talk of this patient. Transmucosal not available in India, oral, very ineffective comparatively. Ranjit is just getting access to oral testosterone undecanoate. We've had it in India since 30 years. We've used it, studied it, and kind of given it up. And there are many studies showing that the bioavailability is quite disappointing. So really the choices between the testosterone gel or a depot injection. If you're looking at this 57-year-old, I would give him the choice that either you can apply gel every day or you can take this injection. For the initial 3 to 6 month period, I would prefer an injection that I would have to repeat every 3-4 weeks, because if he has any side effects, then I can stop the injection. So I would be looking at Sustanon 250 once every 3 weeks. And after 3 months or 4 months at follow-up, if he says he's feeling really better, then I may move on to testosterone undecanoate. Coming to a younger patient, which was your other question, in younger patients who are going to be needing TRT for a very long time, most of them I manage with testosterone undecanoate. Now with undecanoate, you have to realize that the duration between injections varies from each individual to individual. The average duration is 12 weeks, but it may be anywhere from 9 to 16 weeks. So the way we start undeconate, say you have a young patient, severely hypogonadal, maybe hypergonadotropic hypogonadism, is going to need testosterone lifelong. You give him testosterone undeconate injection 1. 6 weeks later, you give injection 2. 12 weeks later, you give injection 3. 12 weeks later, you measure his testosterone. If 12 weeks after the third injection, testosterone is in the lower range of normal, then it means you need to shorten the interval between injections to maybe 10 weeks. If the testosterone level is in the upper range of normal after 12 weeks, you can increase the interval between injections to 14 weeks. And if it's in mid-range, you continue 12 weekly. And then, of course, monitor as Vineet has suggested. Both injections and gel seem to work well, as Vineet had explained very well in his talk. The gel is a little inconvenient, but it's not painful. So and of course, the gel will cost much, much more than the injection.
Rupin, is there any experience of an increased cardiac risk with the gel?
Increased cardiac risk? No, in the reading that I've done, I've not found a problem. But I don't know, if you're asking the question, have you found something like that?
Some of my patients had some amount of chest pain, and so I referred to a cardiologist, 3 patients. So I've been very careful using the gel. So, so I'm not sure if there is an increased risk, or these patients were more susceptible. So I'm not sure. And what is the acceptance of the gel versus an injection in Indian population? I've always found injection easier to convince than a gel.
Yeah. 90% of my patients are on injections. Gel, very few.
Ranjit, what do you prefer in the US?
Whatever the patients prefer. Whatever the patients prefer. Thankfully, we now have access to nasal gel, topical gel, pellets, injection, short-acting injection, long-acting injection, gels, whatever the patients prefer and whatever the insurance companies prefer.
I think in the US, insurance, in the US, insurance would be a major deciding factor.
100%, both for the patients as well as for the doctors.
Yeah.
So, Ranjit sir, maybe for younger patient, you prefer intranasal over the depot injection, as you had shown in slides.
That's correct. Patients who want to preserve fertility, who still haven't started a family, all those patients, yes, if they can take and tolerate the nasal gel and the insurance covers it, yeah.
There you need, there you need to jump in. If I have a young man, say 25, married, and his testosterone is low, he has oligoasthenia and he's trying for a family, I would be giving him clomiphene, not testosterone.
100%. So what the key word there is oligoasthenospermia. So the nasal testosterone gel will preserve your sperm counts. If you want to actually boost your sperm count and you want to improve fertility because it's hormonally induced, then 100% clomiphene citrate.
Which is an important message.
Ranjit, does it mean that since it has a half-life of 1 hour, that's what you mentioned, does it mean it's twice a day?
We use it actually, the FDA has approved it 3 times a day, but most men use it twice a day, yes.
So that's a point that can be made for the transdermal gels also. I don't know what is the experience of the panelists, but I've seen that if you reduce the frequency of application of the transdermal gel in men that wish to preserve fertility, I've had a lot of men that have actually been able to preserve fertility. I don't want to make that as a recommendation on this program at all, but that's been an observation that with the gel also, they do not become azoospermic in a significant percentage.
No, it's a very good point. I mean, I think with the transdermal gel, if you look at the pharmacokinetics, it's actually a lot. Not only does it go up within an hour, it actually stays pretty high for about 4 to 6 hours, which is the difference between the nasal gel versus a transdermal gel. And I think if you have the testosterone levels high for 6 to 7 hours during the day, which is why it's applied twice a day sometimes, then your suppression of HPG axis happens. So if you don't suppress the HPG axis for most of the day, and you're using it only once a day at a lower dose, and patients are happy with it, 100%. There is no secret about the nasal gel. There's nothing fancy about Netesto. It's just short acting. It has a fast peak and a fast drop. And majority of the day, I think GnRH pulsatility is still active, which is why it's able to preserve fertility. And we talked about some of the other side effects that it has lesser compared to the other preparation.
Which raises the question, is it also less effective in alleviating symptoms?
That's a very good question, Rupin. I mean, I'm sure 100%. I mean, we're all thinking about that, right? So we're now finally doing some studies to show, what happens at the blood level doesn't necessarily what happens at the tissue. There's only so many androgen receptors we have. If once the androgen receptors bind to the ligand and testosterone is there, the tissue should work. Who cares that the serum levels are high for 1 hour versus 8 hours versus literally 24 to 36 hours in some injections, and sometimes testosterone levels are high for months on end with the pellets. So I think what happens at the serum level doesn't necessarily what happens at the tissue level. And as long as you have adequate peaks so that the tissues can see and react, you don't necessarily need to have high serum levels throughout the day for good efficacy.
But one might argue that the fact that the pituitary is not getting suppressed would suggest that the tissue levels are not that well sustained.
Yeah, I mean, it depends on which tissue you're looking at, right? We're not giving it for the pituitary gland. We're giving it for the muscle, some important muscles. And so we are actually doing androgen receptor signaling tests in men undergoing penile implants who've been taking nasal testosterone gel versus cypionate versus normal T. And we're actually finding that the AR signaling is actually pretty similar no matter what testosterone preparation they're on. Showing that maybe at the tissue level is probably more important than what we see at the serum level.
Ranjit, is there anything you have done to upregulate nitric oxide synthase by using directly testosterone on the penis as an application?
No, Vasan. I mean, I know a lot of people have talked about arginine, citrulline, to try and improve nitric oxide and to basically increase the substrate, but I don't know of anything. I haven't done anything, but I also don't know of anybody else that has done work on that.
Right, sir. So moving on, let's say we have started him on TRT and injection and recanoate. And so what all tests do you advise and how do you follow up? How frequent do you follow up these patients? Vasan, sir.
Yeah, like it has been discussed, I think Vineet presented this right in the beginning, where he's showed that what are the concerns? The concerns are about the prostate, about the malignancy risk, the polycythemia risk. So I think he has aptly summarized that. He's putting it up again. And I think this is what you need to do. So I think this is a very, 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 very good slide to review and follow it up. And so one of the biggest risks is the polycythemia risk and hematocrit, which is what you need to follow. And this is pretty standard and it's formed as a guideline.
So that's how the EAU guidelines summarize it: 3 months and then 6 months and then annually. You need to go for the physical examination and importantly PSA, hematocrit, lipid and glycemic profile, and DEXA, which needs to be done baseline and an annual. So when he was started on TRT, as Vineet sir has expected, the flow reduced, the IPSS worsened, and the PSA started to rise. Now, coming back to Vineet sir, now how will we proceed in this patient when the PSA started to rise and LUTS has improved?
It's important to understand how much when we are talking in rise, because I think I mentioned in the presentation, it's important to know what this rise of, I mean, if it's just a marginal rise, it wouldn't make any difference. You would consider lowering the dose if there would be an increase in the lower tract symptoms to become bothersome, but otherwise nothing else. But if it's a significant rise, which means that if it's gone beyond his, I'm sorry, what was his baseline PSA? I don't seem to recall his baseline.
Baseline PSA was around 1.6. So it was within 1.2.
So if it is risen to by 1 nanogram per deciliter within this year, then we know that this is a significant rise. And then he's a candidate for stopping TRT and undergoing a rectal first examination, then a trus biopsy.
All right, sir. So let's say the PSA has risen to 4, so 5, or let's say 5. So we have gone for a trus guided biopsy. So
first, you would stop his TRT and do a trus biopsy.
Right. So I would like to bring in Ranjit sir. Is TRT being incriminated as a cause for prostate cancer? Like the patients are going to ask me that my PSA was normal and now I was started with TRT. So should this TRT be incriminated for as a cause of prostate cancer in these patients? So often asked question in OPD settings.
I mean, is it a risk factor? Yes, I think it is still a risk factor. We just don't know who it goes up in and who it doesn't. But I think patients should be warned. Documentation should be done that prostate cancer still remains a risk for men taking testosterone therapy, which is why the guidelines say that if you're going to start TRT in men, PSA should be checked as early as 40 years of age and not 55 like the usual regular prostate cancer screening guidelines. So yes, is there a risk? Yes. But like Vineet said, it should be stopped. We need to make sure that we rule out prostate cancer with a DRE and or a biopsy before you can think about restarting T therapy.
Right. So once we have treated these patients, obviously the Vineet sir has clearly discussed the saturation theory and the suppression theory we know. So I would like to know practical experience from Vineet sir and Ranjit sir in treating patients with carcinoma prostate and TRT, and what is your take on patients who are maybe local, and we categorize in localized, locally advanced, and maybe metastatic prostate cancer, which obviously we don't treat, but in localized and locally advanced, when to treat in these patients for low libido and erectile dysfunction, a similar set of patients.
So
Patients go ahead, sorry.
You take it, Ranjit.
I was going to say the testosterone therapy, someone who's undergone prostatectomy, if the PSA is undetectable at 3 to 6 months, I'm totally okay with starting T therapy, obviously with a small caveat of increased recurrence, but most of the studies have shown it's fairly safe. In people who've undergone radiation therapy, a little bit careful because your PSA is never undetectable. And so in those patients, you just have to be careful and wait till it comes back to completely zero. In patients who've undergone ADT, androgen deprivation, those patients you should be very, very careful and not think about starting TRT because they're now fighting two different battles.
I think totally that's the basic point. And we must remember our difference as compared to the experience of the Western countries. Active surveillance, we talk about other things, low-grade disease and use, our active surveillance is not active surveillance in the true sense. It's actually just, it's not a watchful waiting. It's just let you be. You're not most likely going to get the patient back on surveillance, the surveillance that you're required to follow. And if you tell the patient that you may require a biopsy every time your PSA rises, you're going to have no patient that's going to follow up on your TRT. So the protocol that you require to have for these patients is very rigid. If you're able to maintain that, then barring the surgical patients where it's very easy to decide, you've had a surgery, you've had complete clearance, no margin positive, you've had PSA which has gone to undetectable levels. All right, that's a clean patient that you can start treatment in 6 months or 1 year post treatment. But all other cases, I would be very, very reluctant. I'm very reluctant in all the other men to start TRT, and definitely not in someone who's on androgen deprivation therapy.
And I'd just like to add something is that you have to ask, why do you want to start the TRT? If somebody says, I have libido, but my problem is erection, you don't want to give TRT just to restore erections. You could do that with an oral tablet or an intrapenal injection. So the ones who they say in the US who come asking for TRT are usually, Ranjit, you may correct me, who have general fatigue, tiredness, who've been used to higher levels of testosterone and associate their overall sense of well-being with that. And that is why they push and are willing to take the TRT with the attendant risk, which is not what we see usually in our patients here.
Vasan just said every patient that's walking into his clinic is tired and obese. So how can you say that?
They're tired and obese. That's why they don't attribute it to the low testosterone.
No, I agree with Rupin 100%. Testosterone therapy as a primary modality of treatment for erectile dysfunction is almost useless. In men with mild ED, it may help, but moderate and severe erectile dysfunction, testosterone therapy, especially as a monotherapy, is useless.
Absolutely.
Right, sir. So key message is low risk CA prostate who have been treated with radical prostatectomy and have clear-cut indications may be a good candidate for TRT in CA prostate. I would like to invite Dr. Vasan to provide the key take-home message for testosterone and erectile dysfunction, and Dr. Ranjit to take on testosterone and carcinoma prostate. A few key highlight points to summarize. Vasan, sir, please.
I think the ball was set rolling by Vineet, who brilliantly summarized the use of testosterone, the indication, how when you do the testing and how do you do the patient selection, wherein one of the key challenges in assessment of the symptom of testosterone deficiency is the key area. And I think that is a big challenge in Indian patients, which is what I have realized in my practice, where the questions and how the way you explain the question plays a key role. So assessment is a very important part, and then getting a good test done and confirming the diagnosis. The primary diagnosis has to be confirmed, and post that, depending on the effect of testosterone, whether there is an element of erectile dysfunction, whether there's an element of tiredness as this case scenario presented, or whether there's a lower urinary tract symptomatology. But the key message is that testosterone deficiency presents as a varying symptomatology. And that is what we are trying to discuss. Because of the varying symptomatology, it becomes a challenge to assess. There is a natural aging process because of which men have multiple symptoms. Is it because of a natural aging process, or is it because of testosterone? And it is compounded now because lower urinary tract symptomatology and BPH symptomatology, along with erectile dysfunction symptomatology, are all related to testosterone and could be one riding on the other. And consequently, a good evaluation and understanding the principles of evaluation and understanding the principles of treatment is extremely crucial in initiating any form of treatment of testosterone. And once you initiate treatment, you also need to understand the risk-benefit ratio of a testosterone treatment and understand that testosterone has its risks, and consequently monitoring these patients. So it's a lifelong treatment which you are starting, and especially in the ED scenario. And that is something which you need to understand. And that is the take-home message which I would like to convey to all the participants of this webinar.
And then for
Ranjit,
prostate,
sir, your take on sir.
For the prostate, I think getting a PSA before you start testosterone therapy in men above 40 is important. If the PSA is elevated, workup for prostate cancer with DRE and/or biopsy is a good idea before you start testosterone therapy. Once you start testosterone therapy, monitoring your PSA like the AAU guidelines is probably very important. If there is elevated PSA or the rise in PSA, figure out if it's a real rise in PSA or just an artificial bump. And if it is a real rise, stop testosterone therapy. Again, workup for prostate cancer with DRE. MRI is becoming very common in the US, but certainly trust biopsy, whichever way. Now we're talking about perineal biopsy. So whichever way to rule out prostate cancer is a very good idea. In patients who are treated with prostate cancer, either with prostatectomy and or radiation, symptoms of low libido, lack of energy, generalized well-being, testosterone therapy is a good idea. Should not be used as a primary way to treat erectile dysfunction following prostate cancer treatment.
Sir, we conclude this session, and I thank all the esteemed panelists. Now we move on to the next question answer session, and I hand over the baton to Dr. Raman Tanwar, who will be taking the question and answers.
So thank you, Dr. Aditya. I think all the viewers, they are glued to us, and but we also need to understand this is dinner time. So I will not be asking many questions. I think most of the questions that the audience has asked has already been covered. But there's one aspect I think which has been remaining, which is the testosterone use, or I would say abuse, in the bodybuilders. So there's one question interesting, that some young people are using testosterone for bodybuilding purposes, and how long is this medicine safe? And also with that, I would just like to add a few other points, as in what is the dose that they can take safely? Second is how long it can be taken? What are the disadvantages of taking this? And how to reverse this when the patient comes to you? I think these are the 4 questions that we could summarize in this case, and rest has already been covered. So the first question to Rupin sir, I would say, sir, do you think this kind of a practice being done rampantly in the gyms is safe? And what is your take on that? Rupin sir, you'll have to unmute yourself, sir.
I think as professionals, we should have a clear position that this is unsafe and should not be done. Then people will still do it. So then we will jump to the fourth question, which you had, is how do we help them when they come to us? What I've spoken to several people, and actually I think either the ISM or the SSM had a wonderful talk by one of the speakers where he actually brought in one of his patients who had been a long-term testosterone user and all the things that he went through and the cycling and the rest of that. So the ones who do it on a regular basis probably know how to take care of themselves even better than we could tell them. But in general, if a patient comes and asks me, should I take it? The answer would be no.
Right. So thank you so much for that. And I think we all agree that this is actually an abuse. It's not the use as such. Sir, Dr. Vineet, sir, there's a question regarding this same in continuation. Supposedly somebody has had this problem. You know, they've already been on testosterone abuse and they've taken a PCT, as they call it in the gym, and it's not coming back. Now, basically, what are your algorithms to manage this further?
So a lot of times you have to know whether it's the only thing they have taken, because it may not be the only replacement they have taken. And a lot of these men will take anabolic steroids also. And we know that chronic corticosteroid therapy or steroid therapy will have its own effect on the HBG axis. So once you've ruled out the fact that he's only taken testosterone replacement, then you're going to base it on a. So again, as Dr. Rupin mentioned, they actually know their washout cycles very, very well. So most of them will actually come and tell you that this is how I do the cycle and this is how I do the post-cycle washout. And they would have taken a cycle of HCG or clomiphene and HCG and clomiphene and then come to you. So then you've got to see what their current baseline levels are. What are they looking at? Now, when a man comes to you, he's looking at certain particular outcomes out of it. He's either come to you because he's looking at fertility treatment because he's azoospermic or severely oligospermic, or he's looking at sexual dysfunction or his libido being affected. And you've got to look at what you are correcting. What is it that he's come to you for? What is his current hormone profile? I like to look at what the TE ratio is in such men, because they tend to be on the heavier side also, and can a lot of times have developed a gynecomastia, which is resistant, which then works where the anastrozole will actually work well also. So kind of has a dual role, wherein then I will have them on, if they've not done an HCG washout, then an HCG washout and an alternating anastrozole and clomiphene addition to that therapy.
Right. So thank you so much, Vineet sir. Now, last question to Vasan sir. So have you seen, sir, that in your clinical practice, when you've given all these therapies, there are still patients who have a permanent azoospermia, and what percentage of patients, you know, they may not get their testosterone back? So that's the last question that I have for you. And after that, I will hand over back to Dr. Karthikeyan.
Yeah, definitely. I do see these patients, but luckily for me, I see about 4 or 5 a year. So I don't see very many of them. But when they come, I prefer to wait and see whether if it has been a short duration, depending on when they have stopped the medication. Some of them come to me with saying that they have stopped the medication. Some of them are aware that they have taken it and it could have caused this kind of a problem. Some of them are not aware. Like Vineet said, there are a lot of people who take various other things, and many of them are not even aware what they have taken. So it's a big challenge to assess the impact. And of course, you have the hormonal tests and other tests. So we wait it out and then add HCG as and when it goes along. But I've seen some of them do not respond even after 1 year. And my biggest follow-up has been about 2.5 years, and I'm still waiting with him. So those are only 2 patients who have been in that kind of a scenario. So we are working with an endocrinologist also in that kind of a situation. So those are 2 patients I don't have answers, and they have not yet got back response from. I don't know whether others in the group have seen that kind of men where they have not got back sperm at all in that. But most of them do get back, but the duration can vary anywhere between 3 months to 12 months. That's my experience.
Thank you, Vasan sir. So any of the experts who would like to add anything to this before we kind of conclude our wonderful session on testosterone?
I would agree with Vasan. I've had patients who've been on testosterone for 10 years. Testes have become small, they stop it. We give them all the gonadotropins, they remain azoospermic. So you can warn your patients that sometimes it will be irreversible. In the majority of cases, it is reversible, either as Vasan said, spontaneously, or with a little bit of help from clomiphene, or with HCG, HMG if they are in a hurry. What Vineet pointed out was important because that was discussed in another meeting, that some of these men actually come complaining of low libido and sexual dysfunction because now they've gotten so used to how they feel with very high levels of testosterone that at normal levels, they just feel weak, tired, low libido, and they have erectile dysfunction. So that can be a real problem for some of them.
So thank you, experts. Wonderful to have you all. And I hand over back to Karthikeyan to conclude our webinar.
Thank you, Raman. Thank you, everyone, for being so patient. We have had a 2-hour wonderful session discussion on these 2 cases and also the wonderful lectures. So we have had at least 500 plus registrations who have been actively watching the webinar. So before we conclude, I will like Dr. Aditya to give the final conclusion. Before that, I request the panelists to give their concluding remarks. Rupin sir, Vasan sir, and Vineet sir.
My remarks have already said. I really congratulate you. Excellent meeting that you've planned, and you allowed it to unfold as the panelists jumped in and out. And I think that made it very educative and meaningful. Do continue this. All the best.
Thank you, sir. Sure, sir. Thank you, sir.
Thank you, Karthik, Raman, and Aditya. It was really a nice session, and I think I enjoyed it a lot, and I'm sure the viewers also would have enjoyed it. It's quite, like Rupin said, it's quite informative, and also it was debated in great detail, and I'm sure there's a lot of light thrown on the way to manage these cases. Thank you very much. It was an excellent day.
Wonderful effort, Aditya, Karthik, and Raman. I think this has been a really enjoyable experience. So carry on with this and look forward to many more such.
Thank you so much, sir. We wanted this webinar to done for since a long time, almost I think 5 months. Karthikeyan was the mastermind behind it, and he planned it very well. I thank Karthik and Raman for being part of this. And I thank Rupin sir, Vasan sir, Vineet sir, and special thanks to Ramasamy sir who joined us on a Sunday morning. And all the attendees, over 500 attendees who logged in. And Zydus Group who are launching the new molecule and bringing Avanafil on board. Thank you so much, Sachin and Durjati, for giving the technical support. Thank you so much, all. Have a wonderful evening.
Thank you. Bye.
Yes. Bye. Thank you so much, everyone. On behalf of entire Zydus, I would like to say
Bye,
thanks.
everyone. Thank you.